Heart Muscle Talks. My name is Perry Elliott. I'm at University College in London, and it's a great privilege this evening to welcome our guest speaker, Professor Sanjay Sharma from St George's Hospital in London. I'm joined this evening by my co-chair, Dr. Juan Kasky from Great Ormond Street. Before we start, Max, actually, could you just give everyone a brief rundown of the instructions for how they can participate in the question and answer session towards the end?
Well, you can either post the question in the chat, or there's a Q&A section, I believe, or if they're feeling braver, they can put their hand up and we'll open their microphone and they can ask it personally.
Great.
So,
fantastic.
I think we're ready to go.
So Sanjay, nice to see you again. And I think this evening you're going to be talking to us about exercise recommendations in cardiomyopathy.
Okay, pleasure. And thank you very much for inviting me. So I'm going to speak to you about exercise recommendations in cardiomyopathies, and I have no disclosures for this talk. I'm going to provide a practical and pragmatic guide for prescribing exercise in individuals with cardiomyopathy. I will focus largely on hypertrophic cardiomyopathy because that's the one disease where we do have more information than the other cardiomyopathies when it comes to vigorous exercise. But the benefits of exercise on the cardiovascular system are well established. We know that exercise curbs risk factors for atherosclerosis. So these people who exercise regularly have a better blood pressure and lipid profile. They're less likely to have a high body mass index and therefore less likely to have type 2 diabetes mellitus. Exercise also increases cardiac size, enhances diastolic function, augments stroke volume, and causes good adaptations in the periphery, such as increasing oxidative capacity and capillary conductance. And by doing so, it increases cardiovascular fitness. By that, I mean the increases peak oxygen consumption, which is an excellent objective marker of longevity. And in general, people who exercise live between 3 to 5 years longer than people who don't exercise at all. However, exercise can promote arrhythmias in predisposed individuals and can worsen arrhythmic substrates in some. It's also recognized that exercise may create an arrhythmogenic substrate in previously normal hearts. And I think atrial fibrillation in middle-aged individuals is a prime example of this. But most of the data that we have on exercise and sudden death is derived from post-mortem series in athletes or case series in lots of athletes. But data generally suggesting young athletes that sudden deaths are due to a diverse spectrum of cardiovascular disease, which may have a genetic, congenital, or an acquired basis. But whichever series you look at, in general, the cardiomyopathies appear to be the leading cause, with hypertrophic cardiomyopathy being the most common cause, certainly in the United States. So apart from the actual substrate, such as myocyte disarray that you see here, and the adverse morphological features of this condition, the additional triggers of exercise, such as dehydration, adrenergic surges, electrolyte imbalance, or acid-base disturbance, may promote ventricular fibrillation and sudden death in young people. Now, given that there is certainly a link between exercise and sudden death, and that many individuals lose decades of life from this unpredictable catastrophe, current recommendations for exercise are certainly have been up to recently been very conservative. In general, these guidelines suggest that people who exercise, people who have cardiomyopathies, should not do anything more than low dynamic and low static exercise, such as golf, sailing, table tennis, shooting, etc. Clearly, these guidelines recognize that they are really serving individuals with a very heterogeneous disease process with varying pathophysiology and a varying prognosis. But despite this, they are very uniform. And this basically means that there will be some individuals with very mild morphology and an excellent outlook who will be affected similarly. Due to the nature of these guidelines, of course, people focus on the prohibitive nature of them. There is nebulous information on recreational exercise with these guidelines, which are really designed namely for competitive sports people. And when a physician is attending someone with hypertrophic cardiomyopathy or dilated cardiomyopathy, the aim is really to err on the side of caution and tell individuals not to do much exercise or not much aggressive exercise, And of course, when these patients go on to look at Google, they get a fear of their lives. And as a result of that, many adopt a very sedentary lifestyle. Now, if we look at risk factors for cardiac morbidity and hypertrophic cardiomyopathy, we know that 55% of patients do not meet the exercise recommendations of well-being. These people, 70% of patients with hypertrophic cardiomyopathy are obese or pre-obese. We know that obesity contributes to increased left ventricular mass, obstructive physiology, heart failure, and an increased risk of atrial fibrillation in hypertrophic cardiomyopathy. We also know that sedentary lifestyle confers a greater risk of developing atherosclerosis, which contributes to a worse prognosis in hypertrophic cardiomyopathy. And finally, 1/3 of patients with HCM have high blood pressure. So by becoming sedentary, these people are actually creating substrates that are much worse than the cardiomyopathy itself. Now, if I was writing guidelines on exercise and cardiomyopathy, I would say it is recommended that all able individuals with genetic heart disease, specifically cardiomyopathies in this particular case, should perform a minimum of 150 minutes of mild to moderate exercise divided over 5 days. I'd give this a class 1 and a level B recommendation. So what about moderate exercise? Again, most of this data comes from hypertrophic cardiomyopathy. This is the RESET study. That it was a randomized trial that randomized 67 individuals to exercise and 69 individuals to usual practice. These individuals were middle-aged, mean age 60, 67% were in NYHA1, and they were subjected to a home-based program of moderate intensity exercise for 16 weeks. Initially, these people started with 3 times 20 minutes sessions at a heart rate reserve of 60%, increasing by 5 to 10 minutes per week. And at the end, they were doing 4 to 7 one-hour sessions per week at 70% of their heart rate reserve. And what the investigators found was that these individuals increased their VO2 by about 1.5 mils per minute per kilogram. But importantly, none had any adverse events during this period. A smaller non-randomized study in symptomatic patients with HCM, only 20, but they were older with a mean age of 62, and were in NYHA functional class 2 or 3. These people underwent supervised exercise for 2 hours per week, and in total they exercised for around 41 hours. And in that time, they increased their functional capacity, their NYHA functional class increased, and they did not have any adverse events. So these small studies, although they were not powered necessarily or designed to check the full impact of exercise on HCM, suggested at least that some people, middle-aged and older people, could engage in moderate exercise relatively safely. But what about moderate and vigorous exercise? And over the past 5 or 10 years, certainly, there has been a paradigm shift in this relation, and that people are becoming a little bit more liberal with exercise prescription in hypertrophic cardiomyopathy. And the latest ESC 2020 guidelines were the first really to put their head above the parapet and suggest that some patients with hypertrophic cardiomyopathy could do most sports. And what's the reason for this? Clearly, initially, most of the data from hypertrophic cardiomyopathy came from tertiary centers, which painted a poorer prognosis than we now know. We now know that the annual event rate, serious event rate with hypertrophic cardiomyopathy is between 0.4 and 0.8% in general. We already know that sedentary lifestyle promotes risk factors for hypertrophic cardiomyopathy that have a worse prognosis than the disease itself. We know that among older patients with hypertrophic cardiomyopathy who have self-reported moderate to vigorous exercise, that those people that did moderate to vigorous exercise had a lower morbidity and mortality rate than those people with mild exercise. I should tell you that those people doing a moderate to vigorous exercise were doing 3 times the current WHO recommendations for general health. We also know from Rachel Lampert's ICD registry that individuals with HCM who have an implanted ICD and continue to participate in intensive exercise have not shown an increase in shocks or adverse events. And there is data now emerging that athletes with HCM who continue to exercise don't appear to show an increase in adverse events. And I'll just share 2 studies with you. Here's a study by Antonio Policcia's group that examined clinical outcomes in adult athletes with hypertrophic cardiomyopathy and followed these people up over a 7-year period. So they took 87 consecutive athletes that were diagnosed with hypertrophic cardiomyopathy. The median age of these athletes was 31 years, and they were followed up for 7 years. 61 of these people, that's 69%, decided to stop training or stop competing or reduce training. But 27, that is 31%, continued competitive sport and physical training. Most of these people were in NYHA 1 and 2, and they all had a low ESC score. Only 3% had a high ESC risk score. So we look at the detrained group. These are the people that stopped versus the people that carried on. There is certainly no increase in the number having palpitations or chest pains or breathlessness. Almost 20% developed symptoms over 7 years, which is a 1.3% symptom rate per annum, those people that carried on exercising. There were 2 sudden deaths in the detrained group only, but not in the exercising group. I mean, as I said, this wasn't powered, so I don't think we can take much away from the fact that just because the detrained group died, that exercise is superior to a sedentary lifestyle. We did our own work on 53 athletes, mean age of 38, of which 98% were male. Importantly, 53% of these were professional athletes. In the UK, we don't have to disqualify individuals who have hypertrophic cardiomyopathy. The onus usually is on the athlete and the club that they're exercising with. We can give advice. So these individuals participated in boxing, cricket, cycling, football, rugby, running, swimming, squash, and triathlon. And they had a low 5-year ESC risk score, and around 40% had scar on the CMR. They were completely asymptomatic and untreated. We followed these people up for 4.5 years. During that time, there was no major adverse cardiac event, including no syncope, no aborted sudden cardiac arrest or death, or any evidence of sustained VT. There were 4 cases of de novo NSVT on a Holter, that's 1.8% per annum. And when we looked at the electrical phenotype in those from baseline to follow up, the baseline is the dark blue and the follow-up is the light blue. We found no change in their ECGs over this period, and we found no change in the structural phenotype during this period. But what about these young people that we learn about playing Premier League football? What does their morphology actually look like to allow them to exercise like this? Well, we examined 106 athletes with hypertrophic cardiomyopathy, and we compared these with young patients with hypertrophic cardiomyopathy to check the influence of exercise on disease expression. We found that our athletes with hypertrophic cardiomyopathy had relatively mild morphology, with a wall thickness generally between 14 and 16 millimeters. They had bigger left ventricular cavity dimensions than individuals with who were sedentary, and they had better indices of diastolic function. In about a third, just over a third, LVH was confined to the apex in these athletes, and none of our athletes had evidence of left ventricular outflow tract obstruction. Based on these, I was very pleased to chair the ESC sports cardiology guidelines, and we suggested that we need to be maybe a little bit more liberal in some of these patients with hypertrophic cardiomyopathy at least. I accept that our opinions were largely consensus-based, but we aimed to provide a practical and pragmatic guide for all affected patients, not just for athletes. We provided information on how to assess these people and how to risk stratify them, and we encourage physicians to engage in shared decision-making rather than adopt a paternalistic approach. We also allowed for physician judgment on a case-by-case basis, and we also pointed out that these guidelines were considered to represent good medical practice and were not legally binding, so that cardiologists didn't fear that they would get sued if they didn't conform to these. But the shared decision-making aspect was very important. And this is how we felt we should assess people with hypertrophic cardiomyopathy that were going to engage in moderate to vigorous exercise or even wanted to play competitive sport. So just as we do with normal patients, take a history and examination, looking for certain risk factors such as syncope or a family history of sudden death, and taking them through a plethora of investigations, including an ECG, echo, cardiopulmonary exercise stress test, a Holter or an MRI scan, to assess disease morphology, functional capacity, and to risk stratify them. The exercise test, of course, because we're looking at exercise, was very important. We looked at the maximal heart rate achieved, the peak oxygen consumption, the point at which the anaerobic threshold was achieved, we examined the blood pressure response to exercise, and we checked for complex arrhythmias. By that I mean couplets, triplets, non-sustained or sustained ventricular tachycardia before we prescribed exercise. And of course, the important thing was to follow these people up, even if they were completely well, on an annual basis, and go through most of these investigations. I've sort of suggested, again, I've just pulled this out of the air, that we may be doing MRIs every 3 years rather than every single year in these individuals. But we came up with this, where the green was all go. They could do practically everything except for a sport where syncope may cause trauma or sudden death. The amber was they may be able to do certain amounts of exercise, and the red was that they could only engage in low intensity exercise. And I'd like to walk you through these one by one. So we relied on symptoms and past medical history. We did rely on the ESC score because we think that's the best we've got at the moment. I know they were not supposed to necessarily apply to athletes, but we felt that because that's the best risk stratification model we should choose to use it. We looked at the gradient, the blood pressure response to exercise, and we checked for exercise-induced arrhythmias. So if the individual was asymptomatic and had good functional capacity, had a low ESC risk score, had no or mild LVOT gradient at rest or exercise, had a normal blood pressure response to exercise, had no arrhythmia, when all this was applicable, provided the patient was willing to accept that there would be a slightly higher than normal risk, possibly of sudden death, we did not discourage them from engaging in high intensity exercise on the proviso that they would stop if they ever got chest tightness, breathlessness that was disproportionate to the amount of exercise being performed, palpitation, exertional dizziness, or syncope, and we would monitor these people on a 6-monthly to an annual basis. If they did have symptoms attributed to HCM but with no clear association with exercise, they were considered at moderate risk, or they had a moderate LVOT gradient and attenuated blood pressure, or exercise-induced multiple premature ventricular complexes, or other complex arrhythmias. If more than one of these parameters applied, we suggested they confine themselves to moderate intensity exercise. If clearly they were high risk, by that I mean they had a history of cardiac arrest, unexplained syncope, exercise-induced symptoms, they had a high ESC risk score, a high left ventricular outflow tract gradient, a drop in blood pressure, or exercise-induced complex arrhythmias, then these people should confine themselves to low intensity exercise. And we managed to publish this guideline in JACC, so that to make it a little bit more official than it was initially. So what do we mean by low and high intensity exercise? So as a ballpark figure, low and moderate intensity exercise is a maximal heart rate of below 75%, or exercising at a peak oxygen consumption of below 70% of that predicted for age and sex. Whereas high intensity or very high intensity was a maximal heart rate of over 75% with a peak oxygen consumption of over 70%. And this is how the current guidelines in sports cardiology have shaped up. So if participation in high intensity exercise or competitive sports, if desired, with the exception of those where occurrence of syncope may be associated with harm or death, may be considered for individuals who do not have any risk markers of increased risk that I've already alluded to. So participation in low or moderate intensity recreational exercise, if desired, may be considered for individuals who have any of the markers of increased risk following expert assessment. For gene-positive, phenotype-negative individuals in hypertrophic cardiomyopathy, we did not feel that there was enough evidence to deprive them of competitive sport, but these people should be treated as all the other overt HCM individuals in terms of their annual assessment. So participation in all competitive sports, if desired, may be considered for individuals who are gene-positive HCM, but phenotype negative. For anybody that's considered high risk with HCM, should avoid high intensity exercise, and we should follow these people up on at least an annual basis. And then of course came the HCM LIVE study, and this was a study of 1,660 participants, a very impressive study. The aim of this study was to determine whether vigorous exercise was associated with adverse cardiac events. By that, I mean sudden cardiac arrest, sudden cardiac death, arrhythmogenic syncope, or appropriate ICD shocks. And they enrolled 1,660 participants, mainly from the United States, but also internationally. And these individuals were certainly younger than those that have examined the effects of HCM on moderate exercise. So mean age of 39, 60% male. 961 of these engaged in non-vigorous exercise, but a pretty sizable number, 699 engaged in vigorous exercise, including 259 who engaged in competitive sport. And I don't want to labor this because of lack of time. There was really no difference in the endpoint between vigorous and non-vigorous exercise. And in the entire group, there were 14 cases of either sudden cardiac arrest or sudden cardiac death, giving, my calculation was, an event rate, a very serious event rate of 0.3% per annum, which is no different to that in people who don't exercise. The incidence of an adverse event of any form was about 1.5% per annum. But what struck me about this study was it was different to the athletes that I'm used to seeing. For example, the mean left ventricular wall thickness of these patients was 20 millimeters, so considerably higher than top sportsmen that we diagnose incidentally. The second thing was 40% of these people had an ICD in situ. That's, again, unusual in real sport. Only 25% of these people had late gadolinium enhancement on MRI, which again was interesting. And around 25% of these people had dynamic left ventricular outflow obstruction. And we weren't given the benefit of just how fit these people were because there's no data on peak oxygen consumption. But what this study does show is that exercise certainly may be safe in a proportion of HCM individuals, and that current guidelines may not be too far off the mark. However, there have to be special considerations in adolescents and young adult athletes. So if we look at this study of 1,049 definite or probable cardiac deaths from Barry Maron, we found that the average age of death was 18 years and 65% were under 17 years old. So males seem to be very much affected. Black people and individuals who are engaged in dynamic start-stop sports. And if we look at the natural history of hypertrophic cardiomyopathy, you find that most sudden deaths occur in this age group. Even when we looked at our autopsy study on sudden cardiac death from athletes, we looked at 194 cases. Sudden death was for the first manifestation in 78% and occurred in 74% of asymptomatic individuals. But when it occurred during exercise, it occurred predominantly in men who were young. So based on that, I think we don't want the pendulum to swing a bit too far to the opposite side. We need to be cautious about young individuals, young men, particularly in dynamic start-stop sport. And here I think they may continue after shared decision-making, but we need 6 monthly follow-ups in these types of individuals and annual assessments in all else. So what about arrhythmogenic right ventricular cardiomyopathy? This is predominantly a disease of desmosomal proteins, and the theory is that the myocytes stretch during exercise, causes disruption of the cell-cell junctions, which is then associated with a transient myocarditis and an abnormal healing process that results in fibrofatty replacement of the right and the left ventricular myocardium. There is data from animals and from humans that individuals with ARVC demonstrate an acceleration of their phenotype and arrhythmias and a more rapid progression to heart failure. This study here from Norway looked at 110 individuals with ARVC, of which 65% had overt ARVC and 45 were mutation carriers. They were middle-aged, 34% were athletes, and they exercised vigorously for 4 hours per week. And there was an inverse relationship between the amount of exercise being performed and the right ventricular ejection fraction. So based on this, we have remained conservative with our exercise recommendations for ARVC. There is certainly good data from Norway that participation in 150 minutes of low intensity exercise per week should be considered for all individuals. I would probably go as far as saying low to moderate. Participation in low to moderate recreational exercise or sport, if desired, may be considered for people who have never had a cardiac arrest or ventricular arrhythmias or unexplained syncope, those people who've got minimal structural abnormalities and less than 500 ventricular extrasystoles or no evidence of complex ventricular arrhythmias. High intensity exercise is not recommended, including for people who are gene positive and phenotype negative. So I'd like now to turn our attention briefly to exercise guidelines in individuals with dilated cardiomyopathy. And I think this really is our own experience here at St. George's, many, many years of experience. And this is what we normally do. So if you just look to the left first, we assess the symptomatic status. We ensure that they're on optimal therapy. We assess left ventricular function and myocardial reserve. We do that by doing an exercise echocardiogram. We assess functional capacity by doing a cardiopulmonary exercise test, and we check for exercise-induced arrhythmias. So patients who are patients in NYHA1 who are accustomed exercisers with an LVEF of 45 to 54%, who've got good myocardial reserve, by that I mean an increase in ejection fraction by more than 10% from baseline to peak exercise, those with normal or high peak oxygen consumption, and no evidence of complex arrhythmias, no evidence of extensive scar on the MRI, and no evidence of pathogenic variants in lamin AC or filament C, can probably do most sports. So if your LV is dilated with preserved LV function, there's no family history of DCM, you've got a normal ECG, you've got no arrhythmias, we don't consider you to have DCM, you can do everything. If you've got an unequivocal diagnosis of DCM with an ejection fraction of 45 to 50%, if you're asymptomatic, no other history, good myocardial reserve, normal exercise test or supranormal exercise test, these individuals may engage in all competitive sports. If there's unequivocal DCM with an ejection fraction of less than 40%, in someone who's got symptoms, extensive LG on CMR, now what's by definition of extensive? We're saying 20% of the LV mass. They've got a history of unexplained syncope or arrhythmias on the Holter or ETT. They should not participate in competitive sport and should confine themselves to low to moderate intensity exercise. Gene positive and phenotype negative individuals, we've adopted the same approach as HCM, with the exception of those with lamin AC or filament C mutations. So I'm coming up towards the end of my talk. This is leisure exercise in symptomatic patients with cardiomyopathy. We focus too much on people who feel completely fine and well and want to exercise. What about those people who do have symptoms but are really aspiring to get fit or reduce their risk factors for atherosclerosis? We've got to strike the balance between exercise being a trigger for sudden death and the numerous cardiovascular benefits of exercise. So generally, we would steer these people towards light and moderate intensity exercise. I've already given you the definitions of what I mean by that. In terms of leisure activity, they may go on a stationary bicycle, they may bowl, they may walk briskly, provided they don't become symptomatic. They may golf, do skating, go on the treadmill gently and do light intensity weights. They may even play competitive golf, archery, or bowling. They should avoid sudden explosive exertion, such as sprinting. They should avoid exercising extreme adverse environmental conditions, such as being the environment suddenly become very hot, humid, or very cold. They should avoid exercising during febrile episodes, gastroenteritis, or diarrheal illness. They should avoid exercise programs that involve regular systematic training with increasing workloads focused on achieving high levels of conditioning. And if they're going to do intensive exercise, if they're going to do weight training, they need to avoid free weights. So if I had to summarize this in terms of aerobic exercise, 20 minutes of 3 to 5 minutes of moderate exercise, we like to perform The exercise should be performed at a heart rate that coincides with the anaerobic threshold if you're able to measure it. If you can't measure the anaerobic threshold, then less than 75% of the maximum predicted heart rate in people who are not beta blocked, or less than 70% in people who are beta blocked. When it comes to static exercise, 6 repetitions up to 3 times followed by 2 minutes rest. Use pulley systems, not heavy weights. Do not push more than 20% of your body weight with your upper limbs, and do not push more than 50% of your body weight with your lower limbs. So in conclusion, moderate exercise improves fitness and increases quality of life in individuals with cardiomyopathy. All able individuals with cardiomyopathy should adhere to the current minimal physical activity recommendations. Others should perform symptom-limited physical activity. Moderate exercise appears to be safe in most able individuals with hypertrophic cardiomyopathy and dilated cardiomyopathy. Asymptomatic individuals with HCM and DCM who have a low risk profile may engage in competitive sport, provided they are under annual or at least 6-monthly surveillance. Mild to moderate exercise for up to 2.5 hours per week appears to be safe in arrhythmogenic cardiomyopathy. Gene-positive phenotype negative patients may participate in all sports, with the exception of those who have pathogenic variants in desmosomal proteins, lamin AC, possibly filamin C, and possibly TMM43. Thank you very much for your attention.
Thank you, Sanjay. Really excellent and comprehensive overview of the issues of guidance to athletes, which are clearly complex, but they've evolved a lot, haven't they? I mean, if we go back 20 years, I mean, what would you say have been the biggest changes in our approach to the athlete with cardiomyopathy?
I would say, Perry, it's experience. You know, we've gained so much experience. We've been looking after these young individuals who've had hypertrophic cardiomyopathy, for example. Many of them have been belligerent and carried on doing what they wanted to do. We've had this duty of responsibility of looking after them and found that nothing terrible has happened to them. And I think in the UK, we're quite lucky in that we're less paternalistic and we do respect autonomy. And I think there's been a lot of experience coming certainly from the UK about the benefits. Of course, the Americans, whether they've gone completely the other way with the latest headlines, seem to feel that you can do anything you want if you've got hypertrophic cardiomyopathy. But I think that's what's changed in that, you know, and overall the disease profile, you know, seems to be a lower risk profile than we believed 20 years ago. Most people have a normal lifespan.
Absolutely. Juan.
Thank you very much, Sanjay. That was a really wonderful and comprehensive talk. There are a few questions in the Q&A, but I wonder if I could sort of perhaps ask you something about your thoughts really on exercise recommendations in pre-phenotypic gene carriers. I'm thinking particularly in the sort of pediatric and adolescent population. And you showed beautifully that there are some animal data and possibly some human data for plakophilin, possibly for plakoglobin, maybe some data for lamin AC. But I wonder whether you think we're sort of lumping all of these so-called arrhythmogenic cardiomyopathy genes together and perhaps over-restricting exercise in some of these patients. For example, is there any evidence, for example, in filamin C, for instance, that exercise causes an acceleration of the phenotype developing?
Well, as you may have seen from my body language, I was a bit cagey when I said the word filamin C and even TMM43. I think I even feel a bit cagey when I say all desmosomal proteins. It's going to be like if I had to go back to the future, I think we might be having another conversation in 10 years saying we weren't quite right with how restricted we were with phenotype, genotype negative, genotype positive, phenotype negative individuals. I personally, as far as kids go, these are people that really, we're taking their childhood away from them. So if they're genotype negative, phenotype positive, I think there's really no reason, certainly for HCM at least, I'd say, to deprive these people. Even with ARVC, I think I would keep a very, very close eye on these individuals.
Yeah, thank you, Sanjay. I completely agree with that, and I think that sort of reflects our sort of joint practice. Perry, should we sort of go through some of the questions in the Q&A? So there's a question here from Thanos saying, how would you treat a young athlete with hypertrophic cardiomyopathy who shows only borderline or abnormal blood pressure response to exercise and no other risk marker?
Very good question. I would not necessarily take that as a very high risk marker in these individuals. We do sometimes get people with a blunted blood pressure response, particularly those who've exercised very hard that week. What we have done, we have repeated it with a slightly different profile, exercise profile, and more fluid on board to see if we've actually got this right. So if someone's got just a flattish blood pressure response, i.e. didn't quite increase their peak systolic blood pressure by 20 to 25 millimeters of mercury, that alone I wouldn't worry about. Of course, if they started dropping their blood pressure with exercise, I would be worried, but then I'd expect to see something morphologically or electrically in those sort of individuals.
We don't see it as much now, do we?
Flat blood pressure response?
Yeah. No, I don't know what happened to it. There's people are worried about lamin. So what's the evidence to support sort of a more aggressive approach to exercise limitation lamin? And actually, does it really matter? Because our approach generally to patients with lamin is actually quite aggressive anyway, isn't it?
It is. I mean, certainly there is data from Norway and other countries to suggest that people with lamin AC do accelerate their phenotype, and they accelerate it in many ways in that they get nasty arrhythmias, and they get a very nasty a morphological phenotype as well. So I think in those types of individuals we have to take note. Again, I do monitor these people. We have got individuals, who've got lamin AC who actually manifest very late. So they don't all manifest young. So a lot of our lamin AC are manifesting in their 50s and 60s, as opposed to in early childhood. And these are people that have been exercising all their lives and then suddenly present to us with NSVT and myocardial scar and tell us that their mother had developed heart failure at the age of 90. We start testing them and we get lamin AC positive results.
Yeah, I don't know whether you see this well, but I think the lamins, often some of them are more heart failure families, some of them are more sudden death ventricular arrhythmia families. I mean, some of them, it's not the complete spectrum of the classic phenotype in lamin. Do you see the same?
Agree, but because of the data that we have, when we do treat them, they invariably get something like a bivent ICD, even if they only needed a pacemaker because they've got cardiac conduction tissue disease, because you basically try to cover all possible eventualities in the future.
Yeah, there's maybe one for you, Antoine, here actually. So Eloise is being a bit mischievous, and she's asking about left ventricular non-compaction with normal thickness, normal diameters, especially in young adolescents. What would you do about that group of patients? Right. So again, Eloise, you know more than I do about non-compaction, so I'm not gonna take you on. Certainly not with 68 people listening. But what I can say that if someone is truly diagnosed with left ventricular non-compaction, by that I mean they fulfill echocardiographic or MRA criteria, they've got myocardial scar, they've got left ventricular systolic dysfunction, they've got an abnormal ECG and are showing exercise-induced arrhythmias, I would probably treat them as I would do someone with dilated cardiomyopathy. I'd probably use the same rules for that individual. What about you, Juan?
Yeah, I mean, I would agree with this. I think, the issue of non-compaction here actually is, or at least the way that I've sort of always seen this is that the hypertrabeculation is a phenotypic trait, but that actually what we focus on in terms of clinical decision making, and that sort of applies to exercise restrictions as well, is what is the underlying cardiomyopathy phenotype? So is it sort of hypertrabeculation in the context of left ventricular dilatation, systolic dysfunction, as Sanjay described, or is it hypertrabeculation in the context of left ventricular hypertrophy? And I think I would tend to follow the usual practice for that underlying cardiomyopathic phenotype rather than the non-compaction or the hypertrabeculation itself.
Eloisa says she's very happy with your answer, Sanjay. So
I'm relieved.
This is an interesting question about atrial fibrillation. So what would you advise an athlete? I suppose the implication is with cardiomyopathy who develops AF. Does your advice change?
Well, it depends. So if someone's got, and I'll give you an example. I saw someone yesterday who's got apical hypertrophic cardiomyopathy, has been exercising all their lives, never had a problem, and now at the age of 53 years old, he starts developing palpitation, which make him feel a little bit lightheaded, and he's got paroxysmal atrial fibrillation. Now the question is that the disease? Is it his lifelong exercise, or is it a combination of both? The one thing I did do is I did push an anticoagulant on him, which I may not have done in an athlete who didn't have HCM. He didn't like that very much because he's a cyclist, but I had to take note of the risks of AF in people with hypertrophic cardiomyopathy. But other than that, I would manage them symptomatically. It depends on how bad, how awful the symptoms are. And if the symptoms are, AF is not always well tolerated in people with stiff ventricles. And I think if the symptoms were bad, then I would probably have a low threshold to considering ablation in that sort of person.
Just as an aside, Sanjay, I mean, what's your current thinking, or the general thinking about atrial fibrillation in athletes more broadly? I mean, the general feeling has been that it's a population who are more prone to AF, particularly after, as you say, lifelong endurance. But is that still the case? And if so, does it presage any adverse events in the long term?
Well, that's the space that we need to watch. It's true to say that, for everyone, for the audience that's listening, is that I'm not saying that people who exercise get AF. I think if you exercise a little bit, you may not get AF. So that's very important, that if you're exercising now and you're not overweight and you don't accrue risk factors such as high blood pressure, you could actually stop yourself from getting AF. I'm talking about people who do 15 to 20 times the current recommendation. These are lifelong endurance athletes, and the sort of person that normally gets it is usually a tall male that's exercised in cycling and running and has a high blood pressure response to exercise. And there is no doubt that this is definitely on the increase. I mean, I see far more athletes with this than anything else. And if you ask me how I manage them, important thing, of course, is to exclude any underlying problems that may be staring us in the face, such as coronary artery disease, hyperthyroidism, boozing, performance-enhancing agents that sometimes, you may think this can't be possible because it's a very good athlete. And then what I say now is not evidence-based. I tell them to reduce the intensity and vigor or the duration of the exercise by 20%. It's pulled out the hat. It seems to work for those that adhere to it. Then, of course, we go to the pill in the pocket approach. And if that keeps failing, then we go to ablation.
Sanjay, there's a question here about ventricular ectopy. So particularly in athletes with, the question's about monomorphic ventricular ectopy that doesn't suppress with exercise, but with normal cardiac imaging. What's your approach to that sort of patient?
Well, I think it would be based on several things. So if someone's completely asymptomatic and there is no family history of cardiomyopathy, then I think the morphology of the extrasystoles is quite important. We have to ask ourselves, what sort of extrasystoles do we commonly see in athletes? And these are usually infundibular extrasystoles, conducting with either left or right bundle branch block with an inferior axis, or fascicular ectopic beats with narrow right bundle branch block with either left anterior or left posterior hemiblock. These are common, and these common ones are quite frequent, and they do suppress with exercise. The ones that concern me are the unusual ones. And I'm talking about young athletes now, not the middle-aged and older ones. But if we see a wide right bundle branch block with a superior axis, that's got a very good prediction, especially if it increases with exercise and it is associated with a high burden on the 20 Frat tape. I think if you've got an athlete that's got that morphology that increases with exercise, or if your 20 Frat tape also shows more than 500 of those beats, then there's a 1 in 2 chance you're going to find scar in the left ventricular inferior wall. That's what our experience suggests. So if we find that particular extrasystole, I take that very seriously. I just saw a female who had long COVID, who's a brilliant runner. Everything was fine. I was just about to discharge her, but she wanted to get her fitness checked out on a VO2. We did that, and I saw ventricular extrasystoles with wide right bundle branch block and a superior axis. And I said to her, look, I just want to do an MRI just to be absolutely sure that you haven't got scar due to your COVID. So and then of course the other ones are left bundle branch block with a superior axis, or left bundle branch or right bundle branch with an intermediate axis. The reason I said I don't say this about middle-aged athletes, because when we look at our veteran athletes and we look at 24-hour tapes in these individuals, 12-lead 24-hour tapes, we find that only 40% of these extrasystoles are the usual ones, i.e. the infundibular ones and the fascicular ones. But I really don't know what to make of the other extrasystoles. We haven't been able to correlate those extrasystoles with increased coronary artery calcification, stenoses, or scar on the MRI scan. So I think I have to monitor these.
Yeah, I mean, I think there's a couple of really important messages wrapped up in there. One is that, not all ectopics are the same. So it's, you've got to sort of go to a further level of diagnosis with the ectopics, and it's the role of MRI, isn't it, really, in tissue characterization. Interesting question from one of our participants, who's actually a patient, who thanks you for all your work, and he's asking if you can create a scoring system with all the criteria you've mentioned to individualize the advice in a patient with HCM. Do you think that's possible? So I suppose analogous to the sudden death approach to stratification, can you do the same for athletic prescription?
Well, it's a great question to ask in front of two experts who have actually done scoring systems in adults and pediatrics, and they will tell you that to do this, you would need cooperation from multiple centers. You'd need good data sets from multiple centers, and you need good follow-up. And I think if we could do that, we may be able to create a scoring system.
Nicely sidestepped, Sanjay. Nicely sidestepped.
Sanjay, can I ask you a question? How do you approach an athlete with myocarditis in terms of exercise participation?
Yeah, and sure. And so myocarditis, clearly one of the biggest problems with that, if you don't succumb in the first few weeks from cardiogenic shock or a fatal arrhythmia, that around 70% go on to make a very good recovery with good LV function. And some of these people, considerable number of these people, are left with myocardial scar. Normally the basal inferior wall or the basal infralateral wall. And the question is really what to do with those people. So provided they've had their mandatory 3 to 6 month rest, and they've been rendered, then they're completely asymptomatic with no increase in increased biomarkers, that their exercise capacity is good, they've got preserved LV function, we're not seeing any complex arrhythmias, we continue to watch them. Now, the question is, what do you call scar and a lot of scar? And I think we're not very good at that in sports cardiology, in quantifying scar. People just say scar. But if you ask someone, is it worse? Is it better? When do we start worrying about scar? I mean, at the moment, what I'm doing is keeping an eye. I've got so many athletes under my care with isolated LV scar because I don't know what to do with them. And our medium-term data suggests that the outlook's all right.
Sanjay, have you done any genetic testing in those athletes with sort of isolated scar?
We are starting to. I know that you've all had experience of genotyping these people, and I saw a paper in JACC from the Brompton as well, showing that some of these people had pathogenic variants, in genes causing DCM or even ABC, and we've started doing exactly that. So I genotype my young patients who have had a bad bout of myocarditis. I should also point out for those of you listening that our experience with COVID, we found that 3% of all our athletes that had COVID actually had myocarditis. And this came from footballers in whom we had the luxury of doing every single test after they'd had COVID, even if it was very mild.
So I can hear an explosion in Pavia as we speak. So how did you prove the diagnosis of myocarditis?
We didn't prove it, but I should maybe rephrase that, in that we saw myocardial scar compatible with healed myocarditis.
Okay, all right. Julie asks this is actually a broader question, actually. So she's asking, are there cardio rehab facilities where we can basically take a non-athletic patient with cardiomyopathy and sort of get them on the track towards a more healthy lifestyle? I mean, I think that plays to a broader narrative, doesn't it? Because I think we're starting to understand that cardiomyopathy phenotypes are influenced by other comorbidities, and that managing blood pressure, treating diabetes, but also probably, exercise, as you outlined, is also important in longevity, symptoms, etc.
I mean, I agree, and we have certainly done a feasibility study which hasn't got published yet, where we did take a group of HCM individuals, and they had a supervised exercise program for 16 weeks, where they even did high intensity exercise, and we didn't find any adverse events. But what we found was their BMI dropped a bit. They dropped weight, their blood pressure dropped, their lipid profile improved, and their peak VO2 increased by 3.4 mils per minute per kilogram, which was fantastic. What we did find, and this is what happens when we're surveying people very frequently, that a proportion of these people, because we were doing 7-day event monitors on these people every few weeks, were going from a medium risk ESC risk score to a high risk score. And we found that we implanted prophylactic ICDs in a few of these individuals as a result of that. So that was the downside of it. And the other downside was when we went back to see them 6 months later, after they'd come off the program, everything had gone back to negative again. So their weight had gone up, their blood pressure had changed, their functional capacity had gone back down. So I think the challenge will be in keeping these guys motivated to continue to do that.
Sanjay, Louisa has another question on non-amyloid restrictive cardiomyopathy. Clearly, this is a much rarer group of patients, but and often much sicker. But do you have any sort of insights in terms of exercise recommendations for that cohort of patients?
Well, they don't usually get to me because most of them can't exercise at a very high level. Certainly, on my experience. In that sort of person, I would basically recommend a healthy lifestyle exercise program, such as the current recommendations. I don't have any experience with restrictive cardiomyopathy and vigorous exercise, so I don't think I would be in a position to giving advice in that field. But I would, if I had my pragmatic head on, then the healthy recommendations is what I would be prescribing.
Sanjay, there's a question here about exercise prescription based upon CPET and what we do when CPET's not available. I mean, I think probably in a UK setting, CPET's probably less available than MRI now, I think. So how do you advise without that information?
Yeah, and I said that in my penultimate slide, and that clearly CPET's not available. What we use anaerobic threshold, and the reason why we use anaerobic threshold as a safe marker, we know that at the point that you reach your anaerobic threshold, you do not have a crazy amount of catecholamine in your bloodstream. So you can exercise very, very comfortably at the level of your anaerobic threshold. So we say that if you do not have CPET, then we would say that you are exercising at your anaerobic threshold when you're at around 70% of your maximal predicted heart rate. So that's the roughly what you should use. Obviously, the fitter you get, the higher your anaerobic threshold will become. So these sort of people, you don't just give them one figure. Obviously, they're going to come back and see you again. You do another CPET and say, right, you can do a bit more now because you're fitter than you were before.
Sanjay, there's a question here about how you discriminate athletic adaptation from, in this case, dilated cardiomyopathy, but perhaps I wonder whether you could sort of share your thoughts on discriminating athletic remodeling from hypertrophic cardiomyopathy as well as DCM.
Sanjay, bearing in mind we only have 6 minutes left. Okay.
I was going to say, I actually know a little bit about that. So clearly, a dilated left ventricle with a borderline low left ventricular ejection fraction raises the differential diagnosis of dilated cardiomyopathy. And generally speaking, the ejection fraction that we think would probably be compatible with athletic training would be anything between, say, 45 and 55%. So 45 to 54% could still be athletic adaptation. So in these individuals, clearly, if they're completely asymptomatic, have a normal ECG, by that I mean your usual ECG that you see in athletes who have a good myocardial reserve, by that I mean they increased their ejection fraction by more than 10% from base to peak. And if they've got a high peak oxygen consumption without any complex arrhythmias and no evidence of scar other than right ventricular insertion point fibrosis, I think with those sort of individuals, we would say that they probably don't have DCM. They probably have, but we drew up this algorithm. We're now testing it. We'll see what the results show to see if that actually holds well. I think we'll probably find that we'll have a false negative rate of about 10%, I suspect, something like that. That's some of those guys that we call athletes may actually have DCM.
And maybe the final question. So, colleague Susanna, still just to clarify the Lamin question. So, are we saying that exercise makes Lamin cardiomyopathy worse?
Based on the data available, yes, I would say so.
Short, succinct. Thank you. Sanjay, we're coming towards, well, we're at the end now. I think that's been a really interesting discussion, very broad-ranging. I think we've covered a lot of topics which are of interest to the general cardiology community as well as the more specialized cardiomyopathy community. So thank you very much for sparing the time to talk to us this evening.
Pleasure. Thank you very much for having me.
And the only thing I would like just to finalize with is just to advertise our meeting in Naples in December, between the 5th and 7th of December 2023. This is a meeting organized with the local faculty at the Monaldi Hospital in Naples, dedicated to genetic and rare disease. This will be co-sponsored by the European Reference Network and the International Cardiomyopathy Network, and we hope to see you there. So have a good evening, everybody, and see you again next month.